When the doctor feels the patient needs additional support, I will go in and spend additional minutes with the patient, providing prayer, listening ear, or any type of support and comfort that they may need.
A lot of our patients have religious and spiritual interest. They appreciate the fact that we can talk about that openly.
Welcome to Part 4 in this educational series on integrating spirituality into patient care. This video focuses on health professionals who work with physicians, especially nurses, practice managers, and the person we call the spiritual care coordinator. I begin this section by briefly summarizing 4 key points that we covered in parts 1 through 3 of this series. First, what does integrating spirituality into patient care mean? Second, how do we define the terms spirituality and religion? Third, what are we expecting of physicians and why? And finally, what is the research base that justifies taking the time to do this? After this introduction, I will move into the heart of Part 4, which focuses on the spiritual care team, the spiritual care coordinator as the coach of the team, the meaning of spiritual care, barriers to providing spiritual care, the whole person needs of spiritual care team members, and boundaries that should not be crossed. So, what does integrating spirituality into patient care mean for the healthcare team? Basically, integrating spirituality involves 4 activities. Number 1, first, the physician conducts a brief spiritual assessment to identify spiritual needs related to medical care. Second, the spiritual care coordinator arranges for other spiritual care team members to address the spiritual needs identified by the physician. Third, efforts are made to create an atmosphere where patients feel comfortable talking about spiritual needs with the physician and other team members. And finally, spiritual care is provided to all patients as part of whole person medicine. I've mentioned the word spirituality and spiritual several times now. What do we mean by the term spirituality? How does it relate to religion? And how are these terms used when providing whole person medical care to patients? Most of the research that I reviewed in Part 2 of this series, and that I'll be reviewing briefly here, has examined relationships between religious involvement and health. Religion. Religion involves beliefs and practices related to the transcendent. Religions usually have rules to guide behavior here on earth and doctrines about life after death. Religion is often organized as a community, but it can also exist outside of an institution and may be practiced alone and in private. So religion doesn't always have to involve attending church, synagogue, or mosque, but can also involve private expressions of devotion to the transcendent. Private expressions might include such activities as prayer or meditation, reading holy scriptures, watching religious TV or listening to religious programs or music on the radio. When it comes to doing research, religion is relatively easy to measure and quantify, and it is religious involvement that seems to be related to health. However, religion can also be divisive, since people believe different things and believe them passionately. Furthermore, pluralistic healthcare settings will likely involve patients and providers from a number of different religions, and everyone must respect each other's beliefs. Therefore, the term spirituality has arisen. Spirituality provides a universal language that patients are allowed to define for themselves. Health professionals should communicate with patients using the patient's definition of spirituality, whatever that is. Spirituality for many patients will be their religious beliefs and practices. For others, it may not involve religion at all, although will likely involve something close to it. Next, what are we asking physicians to do? This is important for other team members to know about, since a major task of the spiritual care team is to support the work of the physician. We are asking physicians to do the following. First, conduct a brief spiritual assessment in order to identify spiritual needs. Second, arrange for someone to address those needs. Third, follow up to ensure that spiritual needs are met. And finally, be willing to discuss this subject with patients while appreciating the health benefits of doing so. The spiritual assessment involves asking a few simple questions to identify spiritual needs related to medical illness. The purpose of the spiritual assessment done by the physician is to, number one, make the physician aware of the patient's religious background. Number two, determine if the patient has religious or spiritual support. Number three, identify beliefs that might influence medical decisions and affect compliance with medical care. Number four, identify unmet spiritual needs related to medical illness. Number five, determine if engagement of the spiritual care team is necessary. And number six, create an atmosphere where the patient feels comfortable talking with their physician about spiritual needs affecting medical care. Assuming the receptionist or ward clerk has recorded the patient's religious affiliation in the chart and the physician has access to this information, the spiritual assessment consists of 3 questions. Number 1, do you have a religious or spiritual support system to help you in times of need? Number 2, do you have any religious beliefs that might influence your medical decisions? Number 3, do you have any other spiritual concerns that you would like someone to address? The physician should then document the patient's responses in the electronic medical record. If spiritual needs are identified, the physician should alert the spiritual care team so that arrangements can be made to address those needs. Finally, there should be follow-up down the road to determine if spiritual needs have been adequately addressed. Although the spiritual care team may assist in this regard, the physician should ensure that such follow-up happens. These activities are the minimum requirement we are requesting of physicians regarding the spiritual assessment.
Addressing spiritual needs begins with a spiritual assessment. Spiritual assessment is asking 3 questions. The first question really goes to the heart of the matter. Do you have a faith-based support system to help you in times of need?
Yes.
The response to that question gives me a good idea on where the patient is connected. If they have a community of faith, if they have friends, other people that can be involved in their care when they have needs. The second question is very helpful as a practitioner. Do you have any religious beliefs that might influence your medical decisions?
No.
It really helps to know that up front. We need to talk about those things before we're in a crisis. When I take a spiritual assessment, I'm entering it directly into the electronic medical record. The benefits of having it in the medical record are, number 1, that you don't forget it from patient to patient. It's also helpful if you're taking care of somebody else's patient and there's a need. Do you have any other spiritual concerns you'd like someone to address? The third open-ended question opens up the opportunity for us to talk with them further, maybe to refer them up the line to the spiritual coordinator or to the chaplain. Taking a spiritual assessment is not necessary for every patient every time, but there are some times when it's very convenient. I've found that physical exams are a great time to bring this up. Additionally, when the patient's struggling with health issues, they often want to discuss this, and it's really appropriate to talk to them about it at that time.
Bear in mind that the spiritual assessment is not a one-time event. Whenever there's a significant change in the patient's condition, the physician will want to check whether or not any new spiritual needs have arisen that the patient needs help with. Who does the spiritual assessment apply to? In other words, what types of patients need a spiritual assessment by the physician? There are 5 categories of patients who need a spiritual assessment. Number 1, patients with serious life-threatening conditions. Number 2, patients with chronic disabling medical illness. Number 3, patients with depression or significant anxiety. Number 4, patients newly admitted to the hospital or to a nursing home. And 5, patients being seen for a well-patient exam when time is available to address social issues. In contrast, who doesn't typically need a spiritual assessment? Number 1, patients seen for an acute problem without long-term implications, such as an upper respiratory infection, minor surgical procedure, routine pelvic exam, or some other specific well-defined condition. Number 2, patients seen for follow-up of a time-limited problem where there is no significant disability or challenges to coping. Number 3, children, teenagers, or young adults without chronic illness, life-threatening conditions, or disabling serious medical problems. And number 4, patients who are not religious or spiritual who have indicated that this is an area not relevant to them. Why should physicians do a spiritual assessment, and why should other team members address the spiritual needs uncovered? Here are 7 reasons. First, many patients have spiritual needs related to illness, and addressing these needs affects satisfaction with care, quality of life, and interestingly, may also reduce healthcare costs. Second, religious beliefs influence coping with illness and may affect the patient's emotional state and motivation towards recovery. Third, religious beliefs affect important health-related behaviors and likely influence medical outcomes. Fourth, religious beliefs influence medical decisions made by both the patient and the physician. Fifth, JCAHO standards of care require that providers respect patients' cultural and spiritual beliefs, and assessment is the only way to know what those beliefs are. Sixth, support from a religious community may increase patient monitoring and improve compliance with treatment. And finally, addressing spiritual issues may benefit the health professional as well by providing intrinsic rewards that are associated with delivering whole-person health care. There is also scientific rationale for assessing and addressing patients' spiritual needs. I will quickly review some of that research here. However, for a more detailed examination of these studies, viewers are encouraged to watch Part 2 in this educational series. I begin with mental health and then move on to social health, health behaviors, and physical health. This summary is based on a systematic review of the literature published in the Handbook of Religion and Health. In some areas of the United States and elsewhere in the world, up to 90% of medical patients use religion to cope. Research indicates that the overwhelming majority of these patients report that religion helps them. Religious beliefs are commonly used to endure the distress caused by health problems. Religious beliefs give meaning to illness, promote hope for recovery, and provide behaviors that make the individual feel more in control, such as prayer. Beliefs of this kind have been repeatedly linked with better mental health in medical patients. How, though, is religion related to health more generally? With regard to mental and social health, religious involvement is related to less depression in over 60% of 444 quantitative studies, greater well-being and happiness in nearly 80% of over 300 studies, greater meaning and purpose in over 90% of studies, greater hope and optimism in over 75% of over 70 studies. Because they convey greater meaning, purpose, and hope, religious beliefs and activities are related to less suicide, fewer suicidal attempts, and more negative attitudes towards suicide in 75% of over 140 studies. Religious involvement is also related to less alcohol and drug use or abuse in over 85% of nearly 300 studies, and greater social support, greater marital stability, and more pro-social behaviors in more than 80% of over 250 studies. What about health behaviors, such as exercise, diet, cigarette smoking, sexual activity, and weight control? These behaviors are responsible for nearly 80% of all chronic medical illness. The research shows that religious persons are more likely to exercise or be physically active in nearly 70% of more than 36 studies. Eat a better diet in over 60% of nearly 24 studies. Have lower cholesterol in over 50% of studies. Participate in less extramarital sex in over 85% of nearly 100 studies. And less likely to smoke cigarettes in 90% of over 130 studies. Unfortunately, the more religious had lower weight in only 20% of studies and were heavier than non-religious persons in 40% of studies. Despite being heavier on average, though, religious persons have better physical health than non-religious persons in the majority of studies so far. This includes better immune function in over 50% of 24 studies, better endocrine function in nearly 75% of 31 studies, better cardiovascular functions in close to 70% of 24 studies, less coronary heart disease in nearly 2/3 of nearly 20 studies, lower blood pressure in nearly 60% of 63 studies, less cancer or a better prognosis in more than half of 24 studies, and greater longevity overall in 68% of over 120 studies, including over 75% of the best designed studies. Finally, research indicates that spiritual needs are widespread among medical patients, and when these needs are not addressed by the medical team, this reduces the patient's quality of life and satisfaction with care, and can double or triple healthcare costs. Furthermore, randomized clinical trials show that when physicians conduct a spiritual assessment, this results in a better doctor-patient relationship, better compliance with clinic visits, lower depression in the patient, and a greater functional well-being. In conclusion, based on this review of the research, number one, religion is often used to cope with stress in general and medical illness in particular. Number two, religious or spiritual involvement is associated with greater well-being, less emotional disorder, less substance abuse, greater social support, and better health behaviors. Number three, religiosity is related to less physical illness, better medical outcomes, and greater longevity overall. Number four, spiritual needs are widespread in medical settings, especially in those with serious life-threatening disease. Number five, assessing and addressing patient spiritual needs is related to greater satisfaction with care, better quality of life, less depression, fewer unnecessary health services, better functioning, and a better doctor-patient relationship. Number six, much research is now being done to better understand relationships between religion and health, determine the underlying biological mechanisms involved, and developing new interventions that harness these effects. And finally, given the results of this research, there is every reason for health professionals to assess and address the spiritual needs of patients. Now I'd like to talk about the spiritual care team. Physicians have very little time and may have limited emotional and spiritual reserves. Therefore, they need assistance and support in providing whole person medical care. Each member of the spiritual care team has a specific role to play. First, who makes up the spiritual care team? Number one, the physician. Number two, the spiritual care coordinator, often a nurse or clinic manager. Number three, the chaplain or pastoral counselor. Number four, the social worker. And number five, the receptionist. What are the roles of each member of the spiritual care team? Number one, the physician conducts the spiritual assessment, documents the results, and ensures that the spiritual needs are met by someone. Number 2, the spiritual care coordinator coordinates everything. I will be describing the duties and training of the spiritual care coordinator in a minute. The chaplain or pastoral counselor addresses the spiritual needs of the patient, provides feedback to the spiritual care team, provides spiritual support to other team members, works with the social worker, if available, to develop a spiritual care plan, and follows up to ensure that the patient's spiritual needs are met. Number 4, in hospital settings, the social worker works with the chaplain to develop a spiritual care plan for implementation after hospital discharge and helps with follow-up to ensure that spiritual needs are met. Number 5, the receptionist or other clinic or hospital staff is to ensure that the patient's religious affiliation is recorded in the electronic medical record and is available to the physician.
As a member of our spiritual care team, my role as a physician is first of all to engage the patient, make them feel comfortable so they will be able to open up about their spiritual needs and beliefs. There are times when they don't have support and they need support and they don't know where to turn. So our spiritual care team allows me to connect them with my MA, who is our spiritual care coordinator, and if needed, to a chaplain at the hospital. This network that we have formed has allowed us to meet the spiritual needs of patients that we did not have the manpower or time to do in the past.
Well, you know, days get busy. We have a lot of patients to see, and sometimes we have to move on to the next patient. And so in reality, we have to work as a team, and I'm thankful that I have a team to fall back on.
The spiritual care team has been proven to have benefits to patients. There's quite a bit of data saying that this is important in terms of healing, it's important in terms of patient care, and therefore we should really incorporate it into our practice.
An important part of the work that we do together as a team is to have a monthly meeting. I like to think of it as a spiritual care team huddle.
That gives us a time to talk about patients that have been referred through the system, to know that they have followed up, to take care of any concerns that are ongoing, and to know that, in fact, patients are being taken care of.
Now I'd like to focus on the spiritual care coordinator. The spiritual care coordinator is often a nurse or clinic manager. The duties of the spiritual care coordinator are to review the results of the physician's spiritual assessment, prioritize the spiritual needs that require addressing. The spiritual care coordinator does not conduct the assessment. We want to be clear about that. The assessment cannot be deferred to the spiritual care coordinator since the physician needs to collect this information firsthand. Next, the spiritual care coordinator manages each step to ensure that the patient's spiritual needs are addressed, providing resources as needed. For example, information on local faith communities, spiritual reading materials, information on pastoral care services, and so forth. If a chaplain or pastoral care referral is necessary, the spiritual care coordinator prepares the patient to see the chaplain. In other words, explains the reasons for the referral, describes the training that a chaplain has, and discusses what the chaplain will do. Number 4, the spiritual care coordinator also prepares the chaplain or pastoral counselor for the referral, informing him or her about the spiritual needs identified and why the physician or spiritual care coordinator is referring the patient. After the chaplain referral is completed, the spiritual care coordinator follows up to obtain feedback from the chaplain on the results of the evaluation and information about the spiritual care plan, and then communicates this to the physician. The spiritual care coordinator then helps the chaplain follow up with the patient to ensure that spiritual needs identified during the physician's assessment were adequately addressed by the spiritual care plan. Finally, together with the chaplain, the spiritual care coordinator provides spiritual support to the physician and other members of the spiritual care team, helping them to provide whole person spiritual care to all patients.
Addressing spiritual needs begins with a spiritual assessment. Generally, when doing the spiritual assessment, it's a few simple questions and then we move on. Now, there are times that patients have heartfelt needs that have significant concerns or emotional or spiritual issues, and that's where our spiritual coordinator comes in. I have a person on the staff who can talk to the patients when the time is right, pray with them, lead them, guide them, and refer them to resources outside the office if that's needed.
When the doctor determines that the patient needs more spiritual care, he will come to me and he will ask me to sit down and talk with the patient. Their needs might be prayer. Their needs might be just to communicate and talk. If we make the determination that they need to talk with a chaplain, we have a chaplain available that can come out to the practice and sit down and talk with the patient, or we can give the patient a card and they can contact the chaplain at their convenience.
A lot of our patients have religious and spiritual interest. I talk to them, comfort them, and find out if they need additional help, perhaps through the community.
When the doctor feels the patient needs additional support, I will go in and spend additional minutes with the patient, providing prayer, listening ear, or any type of support and comfort that they may need. That makes a big difference for some people, just to know that they have someone here caring that their spiritual needs as well as their physical needs are also being met.
The spiritual aspect of our practice has been good for the health of our staff as well. It opens the door for people to talk about their spiritual lives, their concerns, and it makes the workplace more healing, more effective.
What training should the spiritual care coordinator have? First, they should complete a spiritual care coordinator training program. Second, they should read the book Spirituality in Patient Care, 3rd edition. Finally, they should become familiar with the content of our 5-part educational series, especially this part, Part 4 and Part 5. The person ideally suited for the role of spiritual care coordinator has the following characteristics. Number 1, a strong, active spiritual life. Number 2, a strong leader, but gentle and sensible. Number 3, is able to relate well with physicians. Number 4, is able to relate well with other team members and patients. And number 5, understands the importance and value of spiritual care. Up until now, I've been talking about spiritual assessment and addressing of spiritual needs of patients. However, I've not yet addressed the issue of spiritual care, so here goes. Although assessing and addressing spiritual needs is part of it, spiritual care goes far beyond that and takes no extra time. The way that ordinary health care is provided can be spiritual. By that I mean recognizing the sacred nature of the person being cared for and the holy obligation and privilege of providing whole person care. More specifically, this means, number 1, providing care with respect for the individual patient, a person with a unique life story. Number 2, inquiring about how the patient wishes to be cared for, rather than providing the same care in the same way to everyone. Number 3, providing care in a kind and gentle manner, even to difficult patients. Number 4, providing care in a competent manner. And finally, number 5, taking extra time with patients who really need it. Spiritual care is the heart of what whole person care is really about and has the potential to bring vitality back into the patient and into the practice of medicine. However, it is not easy to do. Indeed, there are many barriers that prevent the delivery of spiritual care. Research indicates that only about 10% of physicians conduct a spiritual assessment. Why is this so? The following are at least 10 barriers that stand in the way of spiritual assessment and spiritual care. These barriers are based on research by the Harvard Oncology Group at the Dana-Farber Institute. They asked oncologists and oncology nurses why they did not routinely assess and address the spiritual needs of patients. Here is how physicians and nurses responded. Number 1, lack of time. Spiritual care is just one more thing that health professionals are now being asked to do. They barely have enough time to perform required duties and document the results. Many are concerned about opening Pandora's box and not having adequate time to address the issues covered. There is temptation then to eliminate this, quote, optional activity or defer it to others. Response: doing a brief spiritual assessment must be a priority for the physician. It is not optional, but central to providing whole person medical care. The spiritual assessment can actually save time, improve the relationship with the patient, and improve compliance, and make the physician's work more rewarding. The physician, as the leader of the spiritual care team, cannot defer the spiritual assessment to anyone else. The spiritual care team, though, must fully address the spiritual needs that the physician identifies. Number 2, discomfort. Many health professionals are not comfortable addressing this topic, particularly if he or she is not religious or spiritual. Few health professionals have training on how to assess or address the spiritual needs of patients in a sensible and timely manner, or what to do with the spiritual needs if they're identified. Response: comfort comes with training and practice. You are getting the training now, and it's up to you to practice what you learn here. Number 3, fear of making the patient uncomfortable or not knowing how to respond if the patient says, "Why are you asking me these questions?" Response: research shows that most patients are not offended or made uncomfortable when the physician performs a spiritual assessment. And in fact, the majority of patients are thrilled with this. An appropriate response would be, "We are doing this routinely as a show of respect for the beliefs and values of patients, which may influence their medical care." Number 4, spirituality is not important to the health professional and is afraid that the patient will ask about his or her own beliefs. Response: first, patients seldom ask health professionals about their personal beliefs. If they do ask, then a brief or general response usually satisfies the patient. The reason why most patients ask is that they are worried about how the health professional will treat their beliefs. Reassuring the patient that their beliefs will always be respected and honored usually allays this concern. Number 5, the topic is too personal, or there is no space to privately discuss it. Response: health professionals deal with other sensitive areas related to health much more personal than asking about religious beliefs. Sensitive areas include sexual behavior or personal health habits, such as smoking, drinking, diet, or weight control. Fear that these areas are too personal does not prevent health professionals from thoroughly assessing them. Number 6, belief that spiritual assessment is done better by others. Response: the physician is the leader of the healthcare team and needs to know about factors that could affect the patient's health and their compliance to the medical care plan. Number 7, the belief that patients don't want health professionals to address these issues. Response: as I noted before, patient surveys suggest otherwise. Those surveys indicate that only a minority of patients show resistance to such inquiry or wish to keep medicine and religion separate. One large study even found that when patients who did not want a visit from a chaplain and actually got one reported more satisfaction with their overall health care than did non-visited patients. Number 8, concern about the power inequality between patient and health professional might lead to coercion. Response: realize that coercion in this area is a violation of civil rights and so is never appropriate. I will discuss this boundary issue further in the next section. Number 9, discomfort because religious beliefs of the health professional differ from those of the patient. Response: realize that in this era of patient-centered medicine, the focus should always be on respecting and supporting the spiritual beliefs of the patient, whether or not the health professional agrees with those beliefs. Finally, spiritual care is not part of the health professional's role. Response: realize that providing whole person care is part of the health professional's role, and whole person care involves addressing this area. All of these barriers can be overcome through training and practice. It's the practice part that will make the health professional comfortable and fluent in spiritual care. However, there is one major barrier that we have not yet discussed. Little attention has been paid to the whole person needs of health professionals, so we focus on those now. Number one, physical needs. These include the need for regular exercise, eating a healthy diet, controlling weight, regular medical checkups, limitation of alcohol use, and time for rest and relaxation. Number two, emotional needs. These involve the ability to comfortably handle the anxiety and stress associated with providing health care in a high-pressure environment. Health professionals need to be able to cope with the death of patients and the inability to cure a patient's illness. They need to be able to empathize with patients and not be afraid of caring for them. They need to see the purpose and meaning in the work that they do. Number three, social needs. These include spending time with spouse and children, time with friends and colleagues outside of work, and supportive interactions with colleagues during work. Number four, spiritual needs. I will talk about those in a minute. When the physical, emotional, social, and spiritual needs of health professionals are not met, the ability to provide spiritual care and whole person compassionate care will suffer. They will forget what is really important in the work that they do. This is perhaps the number one reason why many health professionals are not addressing patients' spiritual needs. As I noted earlier, integrating spirituality into patient care can't be done by the physician alone. For that reason, we are surrounding the physician with a spiritual care team made up of health professionals who will provide practical assistance, emotional and spiritual support to the physician and each other. The success of spiritual care teams, we think, depends on the availability and use of spiritual resources. Health professionals may choose to develop their own spiritual resources through quiet time spent in prayer, meditation, scripture or inspirational reading, or participation in a faith community. The spiritual care coordinator is in charge of ensuring that other team members have the spiritual resources they need, especially the physician. Spiritual resources such as meditation, prayer, or practicing the presence of God may help the health professional to achieve a relaxed, open state that fosters compassion, increases energy, and enables him or her to provide whole person care. Several forms of meditation exist, although the form chosen to practice will depend on the person's faith tradition. For Buddhist health professionals, mindfulness meditation may be chosen. For Hindu health professionals, there is transcendental meditation, which is often combined with yoga. There are also many forms of meditation for Christian, Jewish, and Muslim health professionals. For the Christian health professional, there is a book by James Finley, a former Trappist monk and student of Thomas Merton, called Christian Meditation, Experiencing the Presence of God. There are also many inspirational books that can be used to develop the Christian health professional's spiritual life. These include The Imitation of Christ by Thomas à Kempis, My Utmost for His Highest by World War I chaplain Oswald Chambers, and Closer Than a Brother by Brother Lawrence. Several forms of meditation also exist for Jewish health professionals. These are described in two books by Ariah Kaplan titled Jewish Meditation, A Practical Guide, and Meditation and Kabbalah. Ray Shagaloff also has written a book called The Secret Art of Talking to God. There are also forms of meditation for Muslim health professionals. A form of prayer called Salat can be considered a meditation. Any short phrase or prayer recited silently or aloud while counting on a string of beads or a knotted cord can be considered meditation when the focus is on God. For example, one meditation could involve reciting and thinking about the meaning of the saying Subhanallah, or glorious is God. Islamic meditations are also described in the book Sufi Meditations by Ibn Ata'Allah and in Sufi Meditation and Contemplation by Scott Kugel. While the barriers I've been describing prevent many health professionals from providing spiritual care, sometimes they go beyond their expertise and do things that are neither sensible nor ethically justifiable. Therefore, I describe boundaries that we think health professionals should seldom cross. I describe 5 don'ts here, most of which are pretty obvious. Number 1, don't prescribe religion to non-religious patients. If religion is good for health, you might think, maybe non-believers should be encouraged to become religious. Not a good idea. Number 2, don't force a spiritual assessment if the patient is not religious. In that case, quickly switch to asking about what gives life meaning and purpose in the context of illness and how this can be supported. Number 3, don't pray with the patient before doing a spiritual assessment and unless the patient asks, or be ready for a lawsuit. While more than 2/3 to 3/4 of patients would like to pray with the health professional and deeply appreciate the offer, others do not. Number 4, don't spiritually counsel patients. Instead, always refer to trained professional chaplains or pastoral counselors. The only exceptions might be if the health professional has pastoral care training or if addressing spiritual issues is urgent and the patient refuses pastoral care or pastoral care is not available. Number 5, don't do any activity that is not patient-centered and patient-directed. Remember, it's about the patient, not the health professional.
We all know that office visits are really very limited time to spend with the patient. If there is an issue that can't be handled, I can send it to my office manager. Also, we have the chaplain that we can call, that we can refer the patient to for more complicated cases. This core group of people, of which I am a part, is what we call the spiritual care team. Having a team allows us to be more effective. Each person has a different skill that they bring to the table. That's extremely helpful when you're dealing with patients because we know that each patient is different.
In conclusion, here are the main points we made in Part 4. Number 1, there are many reasons why health professionals should identify and address patients' spiritual concerns related to medical illness, including research, common sense, and good clinical practice. Number 2, the physician is responsible for doing the spiritual assessment and for ensuring that the spiritual needs of patients are addressed. Number 3, however, the physician cannot do this alone and is backed up by the spiritual care coordinator and the spiritual care team. Number 4, the spiritual care coordinator obtains information from the spiritual assessment and ensures that spiritual needs are fully addressed and spiritual care is provided. Number 5, the spiritual care coordinator, along with the chaplain, provides spiritual support to members of the team. And finally, number 6, there are many spiritual resources available to the spiritual care coordinator to support the physician and the spiritual care team. Those resources will be needed. For more information on how health professionals can assess and address the spiritual needs of patients, I suggest the book Spirituality in Patient Care, 3rd edition. There is also a lot of information available on our Duke Center's website at spiritualityandhealth.duke.edu.